CQC. We have apologies for absence from Paul Rue, who's in Hong Kong, from Robert Francis, who's in New York, and for Jora Gill, who is our new non-executive director, who sends a particular apology because he has a long-standing commitment to be in Australia today, and that commitment predated his appointment to our board, so he's really sorry not to be at his first board meeting, and is likely, well, not likely, he has a clash also for the December board. So his first board meeting will actually be with us, will not be to January, but the dates for the whole of next year are safely lodged in his diary. And I would just say, David, that you and I have had meetings already with Jora, so even though he's not at the board, he's already engaged in our activities. So apologies from those three. Does anybody have any declaration of interest they need to make? Okay. Minutes of the meeting of 19th of October. I don't think that's the right date, is it? Anyway, then our last minutes, are they okay? Does everybody approve them as a true and accurate record? It's the September meeting, isn't it? And is there anything arising from those that anybody needs to raise? Good. So we then have an action log with a small number of items. Does anybody want to raise anything, flag anything coming out of that? They're either on course or, well, they're all on course, or they've got an actual date. Good. Anything else? Sorry. Yes, of course.
Can I just check I understand one thing on the public action log, which is the second item, in which there is a report to be presented to the board considering underlying reasons for failure of providers to improve on re-inspection. It's quite an important issue for and there isn't a date there at the moment. It said there's data and analysis set out in the state of care report. I think that was quite limited reasons. I mean, it reported the non-improvement. I'm not sure it gave much analysis of the non-improvement. I just wanted to be clear, where are we going with that, and when is that coming back to us?
So, David, my understanding is that there is something coming back to the board in due course. The date has not yet been set because the work hasn't been completed. Is that correct?
I don't know, if I'm being brutally honest. I don't need to take it away. Sorry, I don't know the answer to it, Peter. What I would know is that I think this is Paul Bates' initial, which means that this is slightly more historic than it is contemporary. So if you just let me take that away, and I'll come back and I'll give a note round to people. I'm sorry, I should know the answer, but I don't.
Okay. We can't get Paul Bate back, so sadly, so we'll have to do it without him. Thank you. Good challenge. Anything else arising from the last meeting? Okay, so let's move, David, on to your report, please.
Okay. Well, hopefully I do know the answers to some of the questions that might come out of this, but so I'll do this at some speed, if I may, Peter. There's an awful lot here which is referenced in the performance report, and my suggestion to the board is we have the debate about performance on the back of the performance report rather than on the few paragraphs and sentences that I've got in this report. But in relation to adult social care, there's a brief update here on something that Andrea and her team have been dealing with in relation to a particular residential care home where there's been an issue raised publicly about how we have taken the learning from our experience of regulating this home, and what we've tried to do in these 2 or 3 paragraphs is just set out the issues that the teams have been working on, particularly in relation to where we have issues which are raised with us by the coroner and that we need to follow up. And I think what we're attempting to do in these paragraphs is just set out for you as a board the action that has been taken and the learning that has been extracted. We've done an awful lot of work on Regulation 28 and how we can ensure we've got a robust system in place over the past period of time, and I think there's now a system operating which is much more resilient and robust about how we take this forward, with one of Rebecca's legal team taking the lead on these Regulation 28 reports that come in. In terms of hospitals, just a paragraph there updating on those that have gone into special measures and those that have been rated outstanding. The Walton Trust in the North West has been rated outstanding, which is another one added to that select but important group. We've just touched on, in the private board meeting, the agreement for publication of the consultation document on registering the right support, and this public report just gives me the opportunity to reference that we'll be publishing a consultation document in December, which reflects the approach that we're seeking people's views on about how we take that forward, and then pending the receipt of those views we can bring that back to the board for final decision, and that will be the policy we'll operate from March. In the state of care, there's some repetition in here, Peter, about what the state of care report says, yep. But the real paragraph is the very last paragraph of 6, which just sets out the coverage that we received in relation to the report, with Chris Day and Andrea, along with myself, doing a significant number of media events. But even as recently as yesterday in Health Orals, a number of debates in the House of Lords where the report is being quoted in evidence of the state of health and care, which I think is possibly a better reflection than the number of media hits we got on the day of the launch, is the way it's subsequently being used, which I think is important and is worth just reflecting on. Chris Day and his team do some quite sophisticated monitoring of this, including social media as well, which we'll continue to take forward. Paragraph 8, I'm raising the issue about experts by experience. One of the reasons it's in this report, Peter, is that there are a group of ex-experts by experience and some current ones who, I think for the past 3 months, a week before a public board meeting, have written to members of the board raising their concerns and issues. And what I wanted to do in this paragraph is just set out the fact that we are actively monitoring the X by X contract, and indeed since this report was drafted, there's been a performance meeting with Remploy, and there's also been an internal programme board which has continued to review the approach that we are taking. The number of complaints we're receiving around training continue to be made. However, there has been a reduction in concerns raised by inspectors about the quality of X by X support, and the number of X by X's rated good or outstanding by inspectors, because that's what they do after they've been on an inspection, is, and the last performance report was running at 82%. There's been a reduction in complaints about Remploy and communication that are coming into CQC, and there's been a reduction to the executive team in complaints from inspectors. The feedback forms that we're receiving support this overall progress, and we are proposing to remove the requires action notice from the conversations that we're having with Remploy in light of the achievements that are taking place. This isn't to say this is running perfectly, but it is to say that improvements are occurring and are taking place. Remploy are deeply committed to this contract and are working hard to make it work, and in the meetings that I've had with the managing director of Remploy, that's very clear, and I think we can see a trajectory of improvement. There are actions for us. The performance of a contract works 2 ways, and we need to continue to pay attention to ensuring that we're providing Remploy with the fill rates that our contract sets out as well. So I'd want to provide some reassurance to the board that week by week, month by month improvements are indeed taking place in relation to this contract as we extract improved performance from it, and Employee and Choice Support remain committed to it, and we remain committed to it, but we need to ensure that we're continuing to deliver, in inverted commas, the fill rates to make the contract perform at the level. It's a two-way issue. I will write back to the people that wrote in. There's a number of them that not anonymous letters, they're named letters, and we'll provide some more detail than I'm giving here based on the recent performance meetings. But that's the report, Peter.
Thank you. Kay, you wanted to ask David or say something?
Yeah, there's 3 points, actually. The first is to do with the expert by experience contract, and it's good that it's improving. I mean, I think at some point it would be good to do some kind of review or evaluation, either by a user-led organisation or in partnership with a user-led organisation. Not sure what the timing would be, but at some point I think that would be a good thing to do to make sure it's working as we would want, but also people who use services that they would want, how they would want it to work. 2 other points. I agree the State of Care report was very good, lots of good coverage, very authoritative, something to be proud of. So it was a good report, good coverage. And the 3rd point is a small point, but it's an important one. On the registering the right care consultation, I think we may be doing this, but it would be good if we could outreach to some learning disability organisations, particularly user-led ones, to find out what they think about it. There's a new organisation called, I think it's Learning Disability England. It is a user-led organisation, so I think it has to be sort of accessible, but to get some feedback from them, I think would be a good thing to do.
On your last point, I had the advantage over UK because I could see Andrea whilst looking at you, and Andrea was nodding as you were speaking. So, Andrea.
Just to say on that point, Kay, a couple of things. One, I have recently met with Learning Disability England, and so we've got relationships established, which are very helpful, and also with Jill Morell, excuse me, our head of public engagement, met with one of the learning disabilities user-led organisations, Change People up in Leeds earlier this year, and I know that the public engagement team have a variety of those contacts, and I'll absolutely make sure that we're doing that explicitly in this consultation. I'm sure the public engagement team will help us with that, but it's a really, really well-made point, and we will do that.
I did neglect to give one update. It's in Steve's area. I should have done this when we went through PMS. But recently there was one of the decisions that we'd made in relation to the registration of a general practice. We issued a Section 31 notice of decision following an inspection where there had been serious failures. And that was appealed to the tribunal and dismissed. There was then a further appeal to the upper tribunal, and that was remitted back to the first tier tribunal for a rehearing. Anyway, the backwards and forwards in relation to this has now concluded, and last week the tribunal concluded that the GP didn't have an understanding of the importance of complying with the regulations, and that CQC, and this is the important point, were justified in suspending the doctor's registration in relation to it. So I think a further reflection of some of the kind of challenging circumstances and the appeals, which my instinct is that Pulse won't be running this on the front page, but these are exactly the decisions that we're making, and it is an important part of our process that where we're challenged on some of our decisions, they do get this opportunity to go to a tribunal, and this is another successful tribunal hearing from our point of view. And the issue here is really about patient safety, which is why it's important we do these things. But I didn't want to give the report without just commenting on it. Do you want to say anything, Steve, in relation to this? No. Okay.
But Lewis, you did.
Not on that. On general. It's actually about social care.
So you have the floor, as they say.
Okay. Well, first of all, about the State of Care report, I thought they I think came out very well, actually, given the discussions we'd had about it and getting the tone right and the getting the balance between reporting what was good and caution about the future. I was very pleased to see how much CQC emphasised the importance of the social care component of it. That seemed to be one of the main messages that was coming across. Although it was noticeable that quite often that was reported, not because of what we said, but it was reported as if the main problem of social care was in how it was clogging up A&E departments by not doing its job more efficiently. So there's still a bit of a way to go yet in understanding that about the crisis of quality that is also in social care. And as if to back that up, your report is referring to, and I don't think we should let this go without mentioning it, the first prosecution. It's actually, you're referring to the coroner's comments, actually, but it's the same case, case in Nottinghamshire, where there was the first prosecution for corporate manslaughter of a care home or a care home owner. And it's just a reminder of the extent of the problem that can arise in social care. So that's by way of a comment. But my question is that, so here we have the National Regulator of Health and Social Care saying we have reached a tipping point, or we're reaching a tipping point. Now, it could hardly be more serious except to be on the other side of the tipping point, which is where we are in danger of getting. And the question then is what happens next? So our message is a very serious message about the problems facing social care. And we're not the first. It's not the first time we've said it. We're not the only people to be saying it. But what is the next step for something like that? A public statement of the impending difficulties and where they're leading us. What response are we now getting from the Department of Health, from NHS England, from the care home sector itself? Very importantly, can I just get an idea of? I know we published the report and that's out into the world. It's launched into the world. But what next?
So I think comment that you've just made and David made earlier is the first important point. It's not the number of hits to our report or the media coverage. Is it actually influencing policy? And we don't know at the moment. There's certainly been a lot of debate in Parliament referencing both what's seen as a crisis in social care and referencing our report. So that's good. What government decides to do, if anything, is one question, and then the other point that you rightly make is what does the sector itself choose to do? What is it able to do? Andrea, you may want to add to that.
Thank you. So just a couple of comments. One, I think that you're absolutely right. The kind of reflection that we've had about the comments that we've made have focused on the implications for the health service, but the report was very clear about the implications for people who are using services and the impact on their lives and the importance of social care, both in terms of its ability to transform people's lives positively, but also the detrimental impact it has when a 24-hour, 7-day-a-week, 52 weeks of the year experience is utterly miserable, or indeed exposing people to harm and neglect. So I think that we just have to constantly kind of be putting out those messages, as well as demonstrating that people can get it right, and some people do indeed get it right, and there is good practice that people can learn from. In terms of the impact on the different sectors that you identify, the Department of Health, has indeed taken on board, what we've said, and that's it's part of the discourse, I think, within the Department of Health. I mean, I think that Peter's right. We're not absolutely sure where that's going to land, but I think that they are taking it seriously. We are doing work in a variety of different ways with NHS England and other partners on the health side to strengthen the relationships between health and social care in a meaningful way. So supporting, for example, the work of the vanguards around the enhanced health into care homes, where, frankly, the health service can help social care by actually having a much more positive attitude in terms of the way that it supports services. But the final bit, which is the bit about the sector, so we had clearly identified the concerns around resources, but it's not just about resources, it's about how we use those resources and what both care home and domiciliary care providers do with that. And we are undertaking some work across the sector with providers, with commissioners, with other national organisations to say we need to have a better understanding about what good quality care looks like and what a quality strategy for adult social care should look like, which aligns and reflects that which we've got or developing for the NHS through the National Quality Board, which Mike co-chairs with Bruce Keogh from NHS England. So I think that there are a variety of different initiatives that are responding to this, but we've just got to keep on, doing the job that we're here to do, which is to monitor what's happening and report on that, but also to be highlighting some of the things that we think people can do in response.
And I suppose just final thought, Lewis. I think there is now a broad consensus within the NHS that if there is any additional money, that actually it would be most effectively applied into the social care sector. So if that's right, that is a broad consensus, it won't be everybody's view, then actually that is quite a significant policy shift, if you like. Whether it actually gets us anywhere depends on whether there's any money available. But I think we have had an impact in changing thinking.
Just to follow, I think that is very important, and that has been said again this week. I've noticed that. Again, though, does still carry that slight flavour of the purpose of social care is to help the NHS sort out some of its problems, and we just need to remind people that, as well as that being very important, there is an issue of the quality and sometimes the really a poor care in some parts of the adult social care world. It isn't just the issue of discharges and so on from the NHS.
Lewis, my set piece was to make exactly that point at the beginning, that the impact of this, what we're saying about social care, is first, people who should have access to care are not getting it. Secondly, that people who should have access to good quality social care are not necessarily getting it in the numbers that they should. And then thirdly, that washes into the NHS. But the true issue here is unmet need and poor quality. So I get accused of being blunt at times. I think I was pretty unambiguous that this is about adult social care, not about the impact on the NHS. That said, I have no doubt at all that some of the headlines run your point about the media because of what was said about the NHS. So I don't think we should be particularly naive about this as well. Just on this, Chris Day had 70 supportive quotes before the day from user groups and trade associations. A journalist, I'm not going to say who it was, but a very senior journalist, as recently as yesterday, told me that when they try and get stories landed, they will get, well, so what? These people would say that, wouldn't they? And I think what was a game changer, in her words, and this is a very senior journalist, was the regulator said this. So it actually changed the tone of the debate. And if you look at health orals yesterday, I cannot think of a time in the past 4 years when there have been that many questions on adult social care at health orals. I counted 5. And I don't know whether it's just the way our team put it together, but they were the first 5 questions that were asked, not the last 5 when we were running out of time and there was no space. So, the key point is, and I made this point in some of the interviews, the report wasn't to the government, the report is to Parliament. So in a sense, by providing Parliament with the ammunition to have their political debates, I think we did a service. And that will tick over at a different rate than, what is the Chancellor going to do next week when he does the autumn statement. I don't know what he's going to do. But actually, I wouldn't judge our success in the State of Care report whether he does or he doesn't say anything about social care. It is about whether Parliament will debate these issues in a way that's constructive. And I do think we should reflect that we have managed to do something about that.
Okay, are we happy to move on to the performance report? David, we've got a very comprehensive summary, nearly as long as the performance report itself. I don't know that you need to do anything by way of introduction, but if you wish to, of course, please do.
I don't. You've stolen my words. I can both take the hint, but that was also what I was going to do. You have got a comprehensive report. I think the better thing to do is to ask questions. I think there's some very strong performance showing through. I think earlier today we talked about performance against delivering the programme, and I think that's set out. We've got content here about the number of people we've got who are working hard to deliver that, but also some quite granular data. And me and colleagues be very happy to answer any questions that the board have got. There's nothing particularly I want to draw attention to, Peter. In relation to finance, also in this report, you can see that we're projecting an outturn towards the end of the year. Again, Kate's here, and between Kate and I, will be very happy to answer any questions colleagues have got. But rather than witter on, I'll leave it to colleagues to ask questions.
Just finding my notes. You know that the feedback that we get from providers, I just wondered if there was any sort of correlation or association between the ratings we give. So, you know, for example, I'm not going to read anything into it, but I just wondered if, you know, it would seem quite natural if people got a not so great rating to give some sort of more negative feedback. I just wondered if we'd kind of looked at that and maybe given consideration to how we can get feedback that tried to provide sort of more neutral comments. You know, it's very specific on specific things, because otherwise it could give you quite a distorted view as to what, you know, what's actually happening. So it's about whether you've looked at the links and the correlation, and whether there's anything we need to change or amend from that in terms of the feedback we get from trusts. The second point was about corporate complaints. We don't get a report, or perhaps we get an annual report, but I just wondered if whether the board ought to know a little bit more about the types of complaints we get, and whether we're kind of learning from them, because obviously we expect that of providers. We certainly don't get it on a regular basis, but I think perhaps we have an annual complaints report, but it would be good to model what we expect from providers. And the third point was I was looking at the different sort of concerns and alerts, whistleblowing stuff that we get, and I wondered if we'd done any kind of analysis of that information, because I don't think people realise the volume of concerns and whistleblowing issues that we that get raised with us. In fact, I think sometimes people say that that we're not responding, or and I just wondered if there's, I suppose it's similar to the complaints, but if there were ways of reporting more about the sorts of issues that were being responded to and what we actually do with them, and maybe some examples of when things have been raised with us and what we've done.
Mike, do you want to say something on the response to the first point?
Yes, in terms of feedback, of course, we get feedback from a lot of angles, and not just from the provider survey, although the provider survey is very useful because we can get comparisons quarter by quarter, etc. So I and my deputy chief inspectors spend a lot of time getting direct feedback from chief executives and medical directors and others. So we get that informal feedback. In response to your specific question about how does it correlate with ratings, I think there's probably a closer correlation with what people are expecting their rating to be, and if there's a difference between what their expectation is. I don't think we've ever had negative feedback from a trust that we've rated outstanding, nor have we had any challenge on those ratings, I may say. But I think sometimes if a good trust thinks it should be outstanding, there may be comment on that, and one that requires improvement rather than having expected it to itself to be good. So it's not straightforward. In fact, some of the ones we rate as inadequate, they put up their hand first and say, yes, actually this was useful.
I mean, I'd support that, and this is totally anecdotal, but I spend a lot of time with trusts, and the last 2 trusts I visited, literally this month, both were rated as RI. One was complimenting me, as if I'd had something to do with the inspection, on the quality of the work, the usefulness of the recommendations, and this was from the board, and it was, I came away from that feeling really good. And then the other one I went to, I just got an absolute earful about that they regarded the whole thing as a travesty of justice, because exactly to Mike's point, they had an expectation which was not met with either what the inspection saw or, for what it's worth, I saw as I wandered around the hospital. So it's what I think is really interesting, and it's a slightly different point, is that there are a lot of trusts who, and I'm talking specifically about trusts, but actually I think it would apply to right across the piece, who really take our reports as useful work programs, form, where they need to be spending time, and all of that, and that's really positive, however they've been rated. And there are others that are just in denial and arguing and pushing back, and that's really worrying. So that was your first point, unless anybody needs to add anything. David, the second one was around corporate complaints.
Well, we will run a correlation to answer the question across all of the ratings, so we'll do that. But I think slide 23 covers some of this, but Eileen will pick up the...
Okay, I mean, I think, Kay, you make 2 very important points about concerns and complaints, and I think during the time that you and I have worked together, we have had a root and branch review of how we work with both concerns and complaints as a subset of that, and they sit in the Responding to Concerns programme. So the complaints and the performance within complaints and some of the trends in complaints have been reported to the Audit and Corporate Governance Committee. And I think there's an appetite to do that again, and to share some of the learning that we've taken from it, because learning there certainly is. We look for both trends and outlier behaviour, if you like, and individual directorates do pick up on things. So I would suggest that bringing it back again through ACGC is a good thing to do. It might be that we would want to, perhaps annually, as you suggest, bring something to the main board in terms of the state of complaints, and complaints are currently living through a major revision of working practices, and I think that's all to the good. In terms of the volume of concerns that are raised with us, you're certainly right, it's in the many thousands, and part of the Responding Concerns programme has been to make sure that we are well placed to receive some of those which are at the very worrying and troubling end of the life that we as CQC live, to ensure that they're dealt with empathy, with sympathy and with professionalism, and I think we are in a much better place around that, and directorates, each of them can give you examples of where something has been received and acted upon. What we've also done a great deal of work on is setting out with much more clarity what CQC is able to do, what it is not able to do, directing people as appropriate to other bodies who are better placed to actually assist them, and to make sure that when people get responses they are consistent, there's clarity associated with the language, and that they are designed to be helpful. Although we are mindful that we're not always giving people the answer they want from us as a regulator. So the learning from those is certainly drawn out in terms of volumes, understanding better safeguarding issues that are coming through to us, relationships with others. But as I said, for complaints, it would be entirely possible to take that back, particularly through the RGC, which is where it's been already, and to give that an update on progress, and maybe again annually give some sense to the board of the volumes and the types that are received.
Okay, thank you. And then, in a sense, the same comment might apply to the sort of whistleblowing and yeah.
So whistleblowing, indeed, Peter, what we have done is to, under the Responding to Concerns process, there are 3 elements. One is concerns, where people don't want to make a complaint. Then there are complaints, and then there's whistleblowing. Each requires a slightly different response. I've dropped into the shorthand of saying that we sit it all under an umbrella called responding to concerns. And under whistleblowing, I think to be mindful that we have statutory responsibilities around it, but also those that bring concerns to us do not necessarily want to be called whistleblowers, and that's part of the learning that we've taken on board during the process of really revisiting and rethinking all that we do. So we certainly do get some whistleblowing. We're getting a great deal more where people don't want to term themselves as whistleblowers, but they want to share something of concern.
Good, thank you. Anything else anybody would like to raise on the performance report, Lewis?
Can I just ask one question about the number of locations in breach for 4 quarters or more? So this is different from the re-inspection question, although it's sort of related. We've got 1,800 organisations now that have been in breach for over 4 quarters, and although most of them are in social care, actually, so it is partly social care, there's quite a substantial number are primary medical services. We have talked in the past about doing some further work on that group, and I just wanted to know whether that seems a very important group to us about our sort of ability and our sort of ability to, I suppose, confirm to the public that we are driving improvement, not just identifying problems. So just on them a little.
Steve, do you want to respond?
Yeah, I'd welcome the opportunity, actually. Thanks. I mean, our numbers are small. But we know exactly each one of the locations, what's happening to it. So, for example, for general practice, out of hours, urgent care, we have an inspection planned in the diary already for 77%. And then the group that aren't, so that comes down to about 46. So small numbers compared with social care. One of our heads of inspection has an oversight of this and reports to me every month in our own performance meeting. But of those, for example, 16 have already been completed, but CRM, which is the database, there's a delay in actually those numbers coming out onto these figures. So that's a recurring thing. 30 of them are actually in the process of deregistering at the moment. So, and then we can break them down even more. 14 are prisons and slimming clinics. Most of those are in prisons, but we have to follow the HMI prison in their inspection routine. So in fact they might be delayed, but there's nothing we can really do about it unless it's a specific urgent piece of action. And then there are dentists as well, but we have a register with all of them. So some will be minor things, and we have to prioritise whether we send the inspectors in at a particular date, or we complete our programme on time and get our reports out on time. So we make a judgment. But they're small numbers, but we know every single one. And every month I have an update on everyone.
Andrea, do you want to add something?
So, as Lewis quite rightly says, the volume sits with adult social care, and in the sense of the thousands of locations that we are regulating, that's perhaps not surprising. In relation to what we're doing about those, clearly we have a re-inspection process, and so if they've been identified as rated as inadequate, we're back within six months. It could be a lot earlier, and if we've rated them as requires improvement, we should be back within 12 months, and again, it can be earlier. When we identify that they are in breach of the regulations, we are clear about what that breach is and what we're expecting them to do in terms of getting themselves back into compliance with the regulations. And we'll do that either through requirement actions or indeed warning notices, which are public enforcement sort of vehicles that we've got. And we monitor that. We monitor the action plans that people are providing, and we're also working at a local level with clinical commissioning groups and local authorities, because very often it's kind of their role and responsibility to support the improvement in terms of some of the action that might be taking place there. The difficulty, I think, that we've got is that there are some services that will improve in some areas and then drift back in others. So they will look as if they are continuing to be in breach of regulations, but they may well be different regulations that they're in breach of. And that is something that I think we are very mindful of, and is one of the reasons why if the rating of leadership is not so good in adult social care, because obviously what we're looking for there is consistency in performance in terms of improvement, and seeing that happen. But I think that we're on it. The local teams are on it, but there is an issue about what providers are doing in response to that. And we identified in the state of care that we were worried that a quarter of those services that we've rated as inadequate had not improved, and that only about half of the services that we rated as requires improvement had improved, and 8% of them had deteriorated to inadequate. So I think we've still got a real challenge within adult social care to see the improvement that we need to see. And it's not just the regulator that's going to make that happen. It's what the provider themselves are doing, what their staff are doing, and what the local commissioners are doing as well.
Thank you. Jane.
Thank you. Obviously, we're coming to the end of a 3-year period where we've been inspecting everything, and I think we probably could take a moment to say well done, because I think the figures are looking really good. For me, what would be interesting is moving into the next phase, what next looks like, the risk-based assessment, and I would just like to ask whether the board will have a chance to pause and reflect and see what that's going to look like in the future. So that's one point. And the second point, looking on page 13, we've just been talking about social care being at a tipping point. Because when you look here at our ratings, we've got a really quite good, rosy, well not rosy, but hopefully a good picture of what's happening out there. So what is driving the concern? Is it just that the business model, the care is good, but the business model underlying social care just isn't stacking up?
So the answer to the first question is yes, and Andrea to the second.
So you're right, Jane, that overall we're rating services, the majority of services as good. But I think it comes back to one of the points that we were making earlier, which is that the quality of social care impacts on people's entire lives. So a quarter of services requires improvement, and a further 2 or 3% of services being inadequate is frankly absolutely not good enough. So that's one point. The second point is our concern about the fragility and the resilience that there is within adult social care to deliver the improvements that we need to see. So that links back to my response to Lewis's question just now around only half of the services that we're rating as requires improvement actually improving by the time that we go back. And that, I think, is worrying in terms of actually needing to make sure that people are getting the care and the support at the quality that they have every right to expect. And our worry is that with the pressures from a financial point of view, the pressures around workforce, because we have high levels of turnover and high levels of vacancies, both in care assistants, nurses and leaders within adult social care, and also the kind of increasing demand and the acuity of that demand. The sorts of, I was managing old people services in the health service 20 years ago. None of those people that I cared for in the NHS 20 years ago would touch the health service these days. They would all be in social care. So there has been a real change in the level of demand. So it's all of those factors combined together to kind of not give us the confidence that I think we need to say that going forward the quality of care is going to continue to be sustained at the level that we want it to be.
So we're now at the point of the discussion where normally I would sum up and say, are we happy to move on? And then Michael would say, just before we do. So let me break the cycle, Michael, and invite you to say anything if you wish to.
He does more time. It's a success. That's a tactic I'll use in the future. Perfect. Perfect. Good. I'll be happy to move on. Great. Oh, Steve, sorry.
I just thought it might be helpful to give you an update on where we are in GPs with special measures, because that doesn't come out in the report on the activity. As we come to the end of the programme in the next 6 weeks or so, next 6-8 weeks, the last month, so we're still finding the number of inadequate practices at the same rate as we did at the start of the programme, which has surprised us. Because we thought we'd be finding more of the inadequate practices at the start and it would tail off. But in the last 4 weeks, 12 reports, 12 practices have gone into special measures. 4 locations have come out of special measures, of which 2 are rated good and 2 are rated requires improvement, so they've still got a bit more work to do. 1 location remains in special measures because it's still inadequate and at risk. And 3 locations have deregistered, 2 voluntarily and 1 through enforcement. And it's just that the amount of activity we've got is still quite great, and the enforcement activity is quite great. And despite the fact we're nearing the end of the programme, and I thought from the board's point of view it just might be worth bringing that out of the report, because I know Mike did in David's report. I just thought it might be helpful.
Thanks, Steve. All right. Okay, let's move on to the medium-term plan. Is Mark?
So I think Mark will probably appear. I think it's being signalled outside, but if I just say something by way of introduction. Malta, in his previous incarnation as well as this one, and Kate have been heavily involved in this. We've previously talked in private board sessions about the work that's been done on the medium-term strategy group. This is the first time we've brought a report in public. What's the purpose of the medium-term strategy group? The purpose of the medium-term strategy group is to convert Mark, I'm just doing an introduction and you can answer all the difficult questions, so just sit down and compose yourself. So the purpose of the medium-term strategy group is to take the strategy that we published in May and then convert that into a sequence of delivery plans. So what we're working on is a 5-year strategy, a 3-year financial plan, and this will then convert into the business plan that will begin to bring you in December and then for agreement through January and February, Peter, until we get to a public business plan at the February board meeting is the plan. So what this report is attempting to do, colleagues, is just set out, again for the first time publicly, what the strategy implementation plan is that converts the strategy into delivery. And effectively what we want to land here is the approach that we're taking over this 3-year and then 1-year period, where we've worked on the money that we know we're going to get between now and 2019-20, where our budget will go from 249 last year down to 217, which we've called the glide path. How do we go from 15-16 through to 19-20? But also what we've been working on, and again, a mixture of people in finance and in Mark's own area have been taking the numbers and modelling the approach to inspection that we set out in the strategy, converting that into numbers by working with each of the inspection directorates. So the anticipated number of inspections we anticipate doing next year. I think this is why Steve's raising this issue laterally about special measures and GPs, as we begin to finalise those numbers for next year's planning, and then converting that arithmetic, that's modelling, into, well, what does that mean for the number of people we need to deliver the strategy and the numbers against the amount of money that we've got. So what this report is doing is reporting at a high level publicly to the board where we are in relation to the financial glide path and what the implications are at a high level in terms of people, the number of people we employ in CQC to take that work forward, but also to give you some confidence about that this is modelled on the number of inspections we anticipate doing next year. So as an annex to this report, you've got a plan on a page, which I think Paul Rue has asked for in numerous meetings at different times to do this. And this is the work today. We've oscillated between putting lots and lots of detail on this, in which it's a very confusing plan on a page with lots of small writing, or whether there's this plan on a page which has less detail and has bigger writing. The point that I'd want to make is not a cheap one, but is a significant one, that actually underneath each of these lines there is more detail. That doesn't mean these are complete, that this is engineered in its finality, but this is designed to give you some confidence that this degree of detail is being worked up and taken forward. Mark chaired the medium-term strategy group yesterday afternoon, and I spent some time with them, and I know that team are engaged in the detail and considering the detail and critically mapping the interdependencies. So I think we've touched earlier in our meeting today about what some of those interdependencies are, and this is a live discussion in relation to it. So coming back from the plan on the page, what we've attempted to do is, going through the report, is look at the changes to what we've described as our operating model in terms of registration, set out what some of those changes are, same for monitor, going through in the detail of the report, and then just trying to capture the progress of that work, including this important work on IN and T. We've set out, I think this is the first time we've done this publicly, Peter, and just to declare the position on this, Peter and I will be at the Health Select Committee at the beginning of December, so this allows us to use this report as the basis for our public comment at the Health Select Committee. The worst position we could have been in is the first time we were saying any of these was going to be at the Health Select Committee, and then the board and the 3,000 people plus that work in the organisation, the first they hear of it is with Peter and myself at the Health Select Committee. So these paragraphs around the financial position and the people position are hugely important. I hope the board have taken some confidence from the previous performance report that the commitments were made to complete the programme during this financial year 16-17 will be carried through. Lewis, your question is still about the quality of what we're doing, or we continue to work on that. So we do continue to work, not just on the overall number, but the quality of it. But, Peter, what this report is designed to do is just hopefully give the board some reassurance, as well as, I know many people look at this board in public, give people outside of the board the opportunity to see the work that we've been doing and take some confidence from that. No doubt it will also introduce challenge. I do expect the Health Select Committee to ask us some challenging questions about this, but it does allow us to set that out just to be really clear about why this is here. Which is why I'm introducing it rather than Mark, as said, but Mark's probably got a better grip of the very fine detail of this than I have, but I'm sure between the executive team and Mark around the table we'll be able to answer any questions that the board have. But if I leave that there.
So before we get to the challenging questions from the Select Committee, let's have the challenging questions from the board. I would just, Paul isn't here, but I would just say that I think the plan on the page is exactly what I think Paul was looking for. And I think it's the right level of detail as well as the right size font that you've had to use to produce it. So I think it's excellent. Comments, questions, Liz?
Actually, I think it's really helpful to see this kind of thing. When I read these documents, it's clear that we're trying to address the sort of pressing needs of the next year or two, which are partly financial, and they're partly about the changing NHS. And I suppose they're partly because we've come to the end of a cycle in our own work. So those are the three things that have come together. And so it's understandable that what we're trying to say is here's how the organisation will go on from there, and here's what the financial consequences of that might be, of the sort of financial accompaniment of that would be. The slight flaw in that is that there's the risk of losing in that approach the sort of vision thing, the point in a few years' time that we want to be at, and whether whether all of the point we want to reach is properly reflected in that strategy. And I don't mean that in a critical way. I just think that is a natural way of looking at things. It's very easy to focus on the things that are going to hit us in the next year or so. And so, for me, the consequence of that is that it's less clear how we meet what is our fundamental reason for being, which is to represent the patient and the public. So, are we clear what that will look like in a few years' time? Now, I know there are other documents which are partly dealing with that, and what the financial implications of that might be, because you could say that some of our approach to collecting data could be very much driven by what we expect to get to, what point we expect to get to in relation to understanding the public view of the services they use, and for that matter, giving them the information that they might need. So that sense of public accountability, which is at the heart of what we do, doesn't seem so obvious in this kind of document, and I just wonder whether it might be because it's not one of those pressing things that's going to hit us in the next sort of year or so. But in the end, it is the core of what we expect to get to in 3 or 4 years' time.
So I think it's a good challenge, and I think Mark may add to this, but the strategy document itself, there were sections in that, Lewis, that attempted to get what will this look like in 2021. And I can be a nuisance at times, but one of the things I've kept asking the medium-term strategy group is, please will you relate everything back to the strategy? This is the board's position. We've worked hard at getting that, and this is the point why I've emphasised the medium-term strategy group is about the delivery of that strategy. That is our agreed position. It's not for anybody then to do artistic interpretation of that strategy. It is to set out the delivering the strategy. If we feel we need to change the strategy, then that needs bringing back to the board, and that needs to be a board decision to change it. But I've been a stuck record at times where I've said, what does the strategy say about this? And how does this deliver the strategy? And I think what the plan on a page and the detail that sits behind this is literally about how do we carry that forward. I think some of the dilemmas that you've set out continue to exist because this is, it's a rapidly moving environment. How many accountable care organisations will we have next year? We can count 1 or 2, but will it be 3 or 4 or 4 or 5? The precision of the planning is pretty tricky to take forward, not just because the teams are still looking at what's in special measures, what isn't special measures, and therefore what the repeat visits are. But in terms of new care models, just how many will we have next year? We're not going to get these in 18-19. We've got them now, and therefore how do we do some of those things? So I do hope we're mindful of the point that you're making, and we'll continue to try and manage that. But it's good to be reminded.
And Mark, I would assume that you've had that drilled into you at every occasion from David, and that this does.
I most certainly have, yes. As we get more into the detail of the programme here, because this is a programme of change that we've got, then it's really important that we come back to why we're doing it in the first place. So the strategy is that guiding principle, and actually the programmes of work we've set out has sort of set at the starting point what is it we're trying to achieve and how does it impact on patients and the public. So I think we've got that. Another thing I'm really keen to do through the programme is make sure we've got some clear measures of success against that, and that goes right back to the heart of what the strategy is there to do. So I certainly agree there's always the danger we get into that, the detail and lose sight of that. But I think through the work we're doing, trying to make sure we just pull that back, and that every review we do of where we've got to, we'll want to review look at that against the strategy. And the other thing, just to say quickly, on the plan on the paid part of this, what the Audit and Corporate Governance Committee asked us to do was to have a sort of an independent review of our plans as they come through, and I would expect part of that that review to kind of look to make sure that we are holding true to the ambitions in the strategy as well.
Andrea.
And another way that we're doing that to tie both David and Mark's comments together is that we have the 4 strategic objectives set out in the strategy, and we will be kind of setting out the business plan and the median, the kind of planning structure that we've got links to each of those objectives as well, so that we create that golden thread so that we don't kind of go off piste. Mixing my metaphors wildly there, but we make sure that we're actually linking that back to the strategy in a meaningful way, so that we can be saying, how is this contributing to a shared view of quality? How is this ensuring that we're more effective and efficient? How is it ensuring that we're driven with the intelligence in an appropriate way, etc., etc.?
Okay, thank you, Andrea.
So the other side of the coin is that we stick to a strategy that perhaps is no longer relevant. I'm not suggesting we need a whole new strategy, but there's because we're in such a sort of fast-changing environment in health and social care, it could be that the strategy we developed last year may actually need some revision for next year and the year after. So I agree that we don't lose the vision, and we should very much have a strategy, but we shouldn't be concerned about revising that strategy if we feel that particularly the external environment is very different. So not slavishly keeping to the strategy, but in a considered way. It's not a bad thing to review it to make sure that it's still fit for purpose, if you like.
So I think David said that if there was a need to revise the strategy, then that would come to the board for discussion. So, and you're absolutely right, you need to keep these things under review. Having said that, the strategy, I think, was very much aware, as we were writing the strategy, I think we were very much aware of this fast-changing environment. And I'd actually be quite surprised if we chose to change the strategy. I think we will be revising and refining some of the delivery aspects of it as circumstances change. I'd be surprised if we need to revise the strategy, but if we do, then absolutely we will do so, and we'll keep it under review. Jane.
I think the most important words in this document are about, was it flexible and evolving? And then when Lewis was talking just now about things that will hit us, you're absolutely right, Kay. Things will happen over the next few. I don't think we'll go away from the strategy, but we just do need to have in our mind's eye, when things are offered to us, like you've got to measure the use of resources, we've got to do so and so. What are we? How does that fit with our strategic priorities and objectives? And that's what boards are for. Thank you.
So I think strategy is just a set of words if you haven't the ability to implement the strategy. So without taking anything away from all the work we did on the strategy, is really important. Mark, this is absolutely as important, and I think it's a great piece of work you and the team are doing. And so I just want to feed that back through you to everybody else.
Thank you very much, and I'll feed that back to the team.
It's really good.
Peter. Thank you.
That's the good news. Bad news is I'm afraid you'll be back again talking about it from as we go forward. Okay, everybody, we're happy to move on. So well done, Mark. Thank you very much indeed.
Thank you very much.
Thank you. Is Chris out there? Is Chris joining us for? Are you going to do it, Malta? Excellent.
So in front of you is the revised social media policy for CQC that was last updated in 2013, and as we're moving as part of a strategy in a more digital future, as is the rest of the world, as an organisation, we want to encourage our staff to use social media and use it well and make the most of that opportunity for us as an organisation. At the same time, it needs to be clear that what our staff do through social media does not replace and should not replace what we do through our formal corporate communication channels. So this policy is intended to clarify the expectations on our staff when they use social media, and in particular it's modelled on the General Code of Conduct for all our staff and how that translates through to the use of social media. It also provides clarity and consistency for the expectation on more senior staff, where the differentiation between personal views and views as a member of CQC becomes a more grey area, and as a result needs to be clearly set out. And finally, it sets out how we will support our own staff in terms of guidance and training, particularly because some of the social media engagement can lead to more difficult conversations, and how those can be handled well in line with how we want to live our values as an organisation.
Comments? Questions? Lewis?
Well, it's helpful because I think people can get into difficulties in this situation, so it's very helpful to be clear. And I think the most helpful bit is really to say, here's what you do if you get into a difficult situation, here's who you can turn to, here's where you can find advice. I think people do need that because it's surprising and, in fact, quite unpredictable sometimes, the situations you can find yourself in on social media. I mean, there's a kind of mixed message in saying, here's our code of conduct, please stick to it, and at the same time saying, this is social media, your views are your own, go out there and exercise your responsibility as a professional. And I think we just need to be slightly careful that we're not just being a little bit too prescriptive about what people can do in where one of the great virtues of social media is the freedom that it provides and they provide, and the accessibility that it provides to the public to people who are in senior roles. That we just need to make sure there isn't a sort of contrast between promoting that freedom of exchange and placing a set of rules around people which then create an awkwardness about how that exchange takes place. So I don't say necessarily we are doing that, I just think that we have to be rather careful. So when people start documents by saying CQC recognises social media a very important part of public discourse, but here are now several pages of how you should go about it, that slightly jars with me, I have to say. Nothing they're all sensible, but it slightly jars. And I think there is also possibly a slightly different position for board members compared to employees. And that's meant to be protective to employees as well as setting out the rules. Because we're on the board not to defend CQC, although we often do defend CQC. But that isn't our main purpose. The main purpose, as I see it, maybe I've got this wrong, is about that public accountability, is about representing public and patient interests, and bringing in what is sometimes an independent area of interest and expertise to bear in the working of CQC. So it isn't just about working from within the organisation. And we mustn't suggest, or in the way we set this out, suggest any curtailment of that. I think people expect when they write to me on social media, they expect an honest answer, and they don't expect a CQC answer. And of course, it's my duty to be professional and respectful and all of that. And it wouldn't work if I was criticising decisions in a sort of a lively way. But on the other hand, I think people need an honest response, and that, in the end, is what it should be about, particularly for board members.
So I think this is quite difficult for the reasons you've said. I think the way I looked at this was trying to make sure that people didn't inadvertently undermine what we're doing, didn't breach confidentiality. There's all kinds of proper restrictions, without at the same time, absolutely to your point, stopping people being able to have the sort of discourse that you would want them to get to. And we did, Malta, I mean, there was quite a lot of internal discussion and consultation around this. And my understanding is that there was a sort of general sense from those people, I'm not asking David, but those people who do use social media a lot, that this was a good balance. Is that fair comment?
Yeah, that's right. So we've tested it with staff. We've tested it with some board members as well. And the point, Louis, that you're making about if you want the sort of practical advice when things turn into a more difficult situation, I think is absolutely right. That's what the guidance and the training is meant to achieve as an opportunity for support. And also, just to be clear, the alignment of this social media use with a code of conduct is in no means a way to tell people what to say and what not to say. It is to remind them of, as you say, the professional values as well as those situations that Peter highlighted where confidentiality has to be maintained because of a legal process or other rules that we apply as part of a regulatory process. And so it's much more about those boundaries and the clarity of them and the expectations, and of course the honesty and living up to our values. And that's obviously one of our values, so enshrined to them, and it would be part of that. Ultimately, it is not something that is black and white, but something that we as an organisation go in with open eyes and want to encourage in that context.
So, are we happy to endorse them? The policy? I was going to say strategy. It's not strategy, it's a policy. I was looking for the right word. Everybody happy to endorse the policy? Excellent. So we then got the Audit and Corporate Governance Committee report. Paul's not here to present it, but I think it's self-explanatory. Does anybody want to raise any questions or comments? Excellent. So then, is there any other business anybody wants to raise? Good. Right. So that then takes us to the section where the members of the public can ask questions. But before, David, I registered your hand shot up with remarkable speed. But before we get to that, there's a question that was sent to us by Robin Pike, who I think, Jane, is Health Watch in Hertfordshire. Is that right? Okay. Yeah. Anyway, he sent a question, couldn't be here in person, but asked if we would ask the question on his behalf. So I will ask the question. And true work balance between chair and chief executive, I'll ask the question and give David the job of answering it. So the question was, are there any judicial reviews ongoing or pending in relation to CQC inspections?
So thanks. I'm not quite sure what's behind the question, so we will give Robin a written answer to this, but we will ask him what's behind the question. So in answer to the very precise question, are there any judicial reviews of inspection matters, either current or pending, the answer is there are none. But I need to make sure I understand what's behind the question and why he's asking it. But if I was a minister now in Parliament, and God forbid that would ever happen at all, my answer will be there are none.
Right. We won't have a debate about whether you should be in Parliament. So, David, you wanted to... come to come there, put the microphone on, just for... if there is anybody left in the world who doesn't know who you are, just say who you are and then ask whatever question you want to ask.
Well, I'm David Hogarth. I'm a frequent attender at these meetings, and I run a small charity befriending older people in North London. I'd like to start with what is good, and I'd like to thank the CQC for making a positive response to the Your Voice Matters and other people's campaign to stop care homes taking punitive action against people who make complaints. I don't know whether you can stop it, but at least you're on the right side on this. And I'd like to say, I'm sure that Jenny Moore, if she was here, would want to thank you for that. You all know I wrote to you at the time of the cancelled October meeting about the difficulty which people experience in bringing complaints or bringing concerns to the CQC, and Andrea promised to respond to it and did respond to it. As always, her response was very friendly and very polite, but another common feature of every response I've had from Andrea, whether verbal or written, is that the message is always that everything is satisfactory as it is at the moment, and that no changes are required. And having read the State of Care report, and that's another thing I would like to commend you for, I can sort of see why you have to respond this way, and why perhaps you have been reluctant in the past to encourage cameras, why you've been reluctant to look at the way you are inspecting for quality against the caring domain and all the other things. It is at least with care homes, the danger that care homes are going to simply, if they are RI, requiring improvement or inadequate, that they are simply going to pull out of the market. And the trouble is, of course, that it seems to me that there is a sort of conflict of interest for you, because on the one hand, you are responsible and people look to you to maintain quality in the places, in the bodies that you regulate. And on the other hand, you are responsible for oversight of the market. And if you, by inspecting more vigorously, cause a number of care homes to disappear, you will increase the amount of bed blocking, and nobody is going to thank you for that. Now, I personally feel that it should not be possible for a care home which has been criticised simply to disappear. I think that's completely wrong. It doesn't happen with hospitals, and it shouldn't happen with care homes either. But I would like to see the CQC lobbying government to make that impossible, so that you could be freed up to do the sort of vigorous inspecting which you ought to be doing. Alternatively, if perhaps the conflict of interest should be addressed by your not being any longer responsible for market oversight. As I do believe that, having heard you talk today and known you for a long time, that you really do care about quality. That seems to me your primary function. I think market oversight is a later function and a secondary function. And I would like to see you freed up to do that, to look at your primary function, that quality comes absolutely first. And if you can't do that, if you keep market oversight, then to think perhaps there is another body, perhaps Health Watch or something of that kind, which should do the inspection of without the conflict of interest of which I've been talking. So that's where my thinking has got to at the moment.
David, before I ask, before I ask Andrea to respond, I mean, first thanks for the nice things you said. So thank you for those. I think you've misunderstood what our responsibility is in terms of market oversight. There is no conflict of interest. We are not responsible for the market in the sense that you're suggesting. What I do think there is a Solomon's judgment at times as to whether the users of services are best served by a particular service being maintained or not. That is a really difficult judgment which Andrea and her team have to make quite regularly. But it's not in any way influenced by the market oversight, which is a completely different set of responsibilities. And it's just really important to be clear there is no conflict. Andrea, do you want to add to that?
Yes, just to amplify that, because you are absolutely right. There is not a conflict of interest. Quality is the absolutely, Lewis said this earlier, that is the reason why we exist. That is the reason why everybody around this table and all of the people who work in CQC get out of bed in the morning, is to make sure that people are receiving care and support which is high quality, effective, safe and compassionate. And the market oversight responsibility is in relation to us having oversight of what is happening in those providers where, if there was a service cessation because of a business failure that would damage the continuity of care for people, that we would be able to identify that and provide early warning notification to local authorities that that was the case. So actually it is about, in a sense, quality, because one of the aspects of quality is ensuring that people do the right things in response to a threat and to the continuity of care being delivered. So there is absolutely no reason for that oversight and responsibility that we have in respect of the larger services that would be difficult to replace, to compromise our ability to assess quality on an individual basis in every single inspection. And equally, and Peter's right again, there are judgments to be made, and we have an enforcement process guided by our colleagues in the legal services team to assess the action that we take in response to the difficulties that we find. But poor capacity in adult social care is no capacity at all. And if we genuinely believe that people are at threat of abuse, harm or neglect, then we will take the action that we need to take. And my colleagues in primary medical services and hospitals do this too. You've heard Steve talk about it already earlier today. We will take that action, because that is the right action to take, and that's one of the reasons why integrity is one of our 4 values, because doing the right thing is what we're expecting our staff to do, and is certainly what we are committed to delivering.
Well, I was looking for a reason, for an excuse, and I may have got the wrong end of the stick about market oversight. But if market oversight is not a barrier to inspecting more vigorously and to gathering intelligence more vigorously, then, why are you not doing more to be, as I've said in the past, like MI5, to really get to the bottom of what is going on in care homes, particularly in, say, the caring domain, but in many domains? It's not just about abuse and so on. There's the mediocrity of the care which people are getting. And, I'm delighted to hear that you are not subject to these sort of constraints. But if you aren't subject to these constraints, then I think there are a lot of people around who would think that you could be doing a great deal more than you're doing at the moment.
So on that point, the inspection regime that we currently have is indeed more thorough and rigorous than it was previously. And you and I have corresponded and discussed on several occasions, David, as to ways that we could improve that and suggestions that you've made and things that we have taken on board. We will be coming out in December of this year with a review of our assessment framework, where we are looking at the key lines of inquiry and the prompts that we expect our inspectors to follow in terms of looking at each of our 5 key questions and the evidence that they look at. So there's a further opportunity for us to refine that process. But I think that we do get, we may not get to the bottom of absolutely everything, because we do not sit on the shoulders of every single provider 365 days of the year. Nobody is going to expect the regulator to do that. But we do identify problems, we respond to the concerns that are being raised, and we are taking action in a variety of different places, both to enforce improvements where that improvement is possible, but also to take action that restricts people's admissions so that they don't exacerbate the problem while they're fixing it, or indeed to cancel their registration if we believe that there is no way that that improvement is going to be delivered and it is putting people at serious risk of harm. So I think there are, and we've demonstrated that in the state of care, we are taking more enforcement action as a proportion of our activity and taking more kind of serious enforcement action and using our powers of prosecution, which we've done and successfully concluded 2 cases this year. So there are a variety of ways that we are improving, or we have improved, which is not to say that we're perfect, because we're not, and there are always things that we can improve, and we will continue to look to do so.
So just in summary, David, I can absolutely guarantee that none of our decisions are influenced by market oversight, because, as I say, that actually has a completely different function. And then on your second point, we've had many discussions, you and I, both here at this board and separately, and the answer is we're never going to agree. We just have a fundamental difference. I do not personally believe, and I don't think the board believes, that we should be acting like MO5. I think there are limits on covert surveillance. I think you have to take into account privacy and dignity of both service users and of staff. So, we just disagree, and I'm afraid we will always go on disagreeing because you have very strong views, which I respect, but they're not the same as mine.
Well, perhaps I shouldn't have mentioned MI5, but mistake. But I admit you enforce, yes. I'm not quarrelling with your enforcing. Maybe Jenny Moore might, but I don't. It's about finding out what is going on. I gave you some tables back in February and June, which showed that in a great many cases where things were definitely going wrong and had come out in the press or and on Panorama and so forth, but you had not discovered this. Then I thought, why is that? And I thought it was possibly because people are not willing to bring things to the CQC. So then I produced these 5 ideas about how you could make it. I would hope that you would just look at those ideas and see whether, in fact, you could do a little bit more to encourage people to actually come to you. I know it might be a Pandora's box, but, nonetheless, it's probably, you could be prouder of what you're doing if you opened that Pandora's box.
And I think that if you look at the performance report, you will see the thousands of contacts that we get through the customer centre of people raising concerns with us. Undoubtedly, more can be done, and certainly more can be done of those professionals, health professionals and social care professionals who are going into services and seeing some of these things that are happening, and absolutely have a professional responsibility to share that with us. So I think we need to be opening up all avenues for people to share that information with us. David, I agree with you.
And I'm very proud of the work that your team do, Andrea. So, is there anything else? Thank you, David. Is there anybody else in the public want to raise anything? Great. I have one final piece of any other business, Kay. Kay, this is your last meeting.
It is, yes.
Nine years.
Well, it's 8 years with CQC, yeah.
Well,
in fact. Yeah,
yes,
getting
but
into 9.
It's
yeah.
nine in total of huge service, and I think we are all very grateful for what you've done. I think particularly more importantly, I think service users generally should be very appreciative of your efforts. So I just want to thank you on behalf of everybody, and I have, excuse me, David. My personal interflora got here just in time. We're running ahead of ourselves.
Thank you.
I love flowers. On behalf of the board.
Thank you.
And thank you
Thank
very
you very
much
much.
for all you've done.
Thank you. That's much appreciated.
And that, as they say, is that. Thank you, Will. And, sorry, what I was going to say is that since we are happily running ahead of ourselves, having got behind earlier this morning, can we have half an hour for lunch and then for the second part of the private board start in half an hour? Which might, Lewis, get you to your train on time. Great. Thank you all.